Welcome to the Patient Advocacy Show. I am Jori Enfield, along with our Patient Advocacy Club members and research team at Touro University California. Disclosure: the views shown in this presentation may not necessarily represent the views of Touro University. In this episode, we will analyze new verbiage in the 2021 CPT manual regarding guidelines for office and outpatient evaluation and management services. Specifically, we will look at one paragraph on page 12. This one paragraph is interesting because it replaces nearly 2 pages of content compared to CPT manuals from 1995 through 2020. 25 years and now a big change. The purpose of this community outreach video is to analyze this one paragraph, sentence by sentence, and discuss what our healthcare community may need to do in order to accommodate the new rules, while making the practice of medicine better for patients, providers, and medical staff members. In the description of this YouTube video, we include an IRB-approved survey. I invite you to watch this video and then click on the link. We would like to know what you feel about these new policy changes and also ask for comments. Okay, we are addressing one paragraph in the CPT manual. What is the CPT manual?
CPT stands for Current Procedural Terminology. The CPT manual is a yearly publication copyrighted by the American Medical Association, which lists all of the codes for medical services and procedures. 98925, for example, is the CPT code for administration of osteopathic manipulative treatment, or OMT, to 1 or 2 body regions. If a medical provider sutured a 4-centimeter laceration on a patient's leg, that would be represented by CPT code 12002. These CPT codes are important because they form a means of identifying and tracking services and procedures that are performed by medical providers on patients. It matters for payment and for work done by medical professionals, and it also guides on how health record documentation should represent patient care. The CPT manual also has printed instructions. So today we are talking about instructions regarding outpatient and office E&M services. So think of office visits. These are CPT codes 99202 through 99215, which of interest represents 20% of all payment to medical providers by Medicare. The CPT manual is continuously updated with the Centers of Medicare and Medicaid Services, or CMS, in charge of making policy, working with a CPT committee and the AMA RUC. The RUC is the AMA Specialty Society Relative Value Scale Update Committee. In 2018, the CMS asked the CPT committee and the RUC to help change the rules. Their response is captured in the one paragraph we are discussing today.
Well stated. Overall, you can think of CPT codes as numeric, sometimes alphanumeric, codes to represent each medical service or medical procedure. You can think of the CPT manual as federal guidance for how to document patient care in the health record. This guideline paragraph addresses E&M office outpatient services. What is an E&M service and why mention outpatient?
E&M stands for Evaluation and Management, which typically involves a history, examination, and medical decision-making. The history, per 1995-1997 documentation guidelines, is nearly 30 standardized medical interview questions. The examination is a physical exam, such as what the medical provider observes when listening to your heart. Medical decision-making is the provider's assessment and plan. Elements of medical decision-making include addressing diagnoses, analyzing, ordering, reviewing data, and risk. Office and outpatient correspond to the place of service. Requirements such as documentation and coding are different depending on the place of service, such as outpatient office versus inpatient hospital versus emergency department. Let's say you are a patient and you attend an office visit with a medical provider. That office visit is an outpatient evaluation and management service. For short, you can say an office E&M.
Thank you. Let's tackle the first sentence. Office or other outpatient services include a medically appropriate history and/or physical examination when performed. What does this mean?
It means the provider is no longer mandated to document a specified volume of information regarding the history or examination into the health record in order to get credit for the service and survive medical audits that may look back to this service in the future. It is now up to the medical provider to document only what she feels is medically appropriate. For the history, for example, per old guidelines, the level of service was based on the number of questions asked and answered in the health record. The more information entered, the higher the level of service and higher payment. Now, the rules have changed to simply permit the medical provider to document what is medically appropriate.
Why was this 25-year policy changed? It sounds like history and examination are being eliminated.
Our government recognized that the old rules forced medical providers to be overly burdened with health record documentation tasks, to the point of potentially needing to put more focus on the medical record than on the patient. CMS knew that there was a problem and started the Patients Over Paperwork initiative in 2017. CMS Administrator Seema Verma authorized the initiative with the goals to improve the system in response to a 2017 presidential executive order to cut the red tape. In 2018, CMS proposed a series of policy changes to help medical providers better focus on the patient and worry less about the volume of data required for health record documentation and payment for services. The biggest policy changes reflected in this one paragraph took effect January 1st, 2021. The history and examination are not being eliminated from patient care. Documentation of the history and examination, however, is being removed from the physician payment formula. As addressed in the first sentence, providers document what they feel is medically appropriate when a history or exam is performed.
Let's address the second sentence. The nature and extent of the history and/or physical examination are determined by the treating physician or other qualified health professional reporting the service. What does this mean?
This builds upon what Kyle said. This sentence of the guideline means it's up to the medical provider to determine what is necessary to document.
Why would this be good? Let's say for a medical provider documenting an examination.
1995-1997 documentation guidelines require documenting a long list of physical examination findings to qualify for a particular level of service, which corresponds to a certain level of payment. In the past, a provider could document details that they thought were sufficient to describe clinical examination findings, but a medical coder or auditor could come back a year later and say, you documented 4 exam items, but it looks more like an expanded problem focused rather than a detailed exam. Therefore, we want you to refund some payment. That doctor may have actually documented 10 observations, but because what the doctor documented did not match with the auditor's checklist, the doctor is punished financially. These new rules regarding history and examination encourage the provider to document what they think is medically appropriate and not think about documenting just for the sake of satisfying an auditor's checklist.
Gathering the history is addressed by the next sentence in the new guideline in CPT. It reads, the care team may collect information and the patient or caregiver may supply information directly, for example, by electronic health record portal or questionnaire, that is reviewed by the reporting physician or other qualified healthcare professional. What does this mean?
This statement makes it clear that patient or a caregiver, such as a parent, can answer history questions before they meet with the provider and have their answers accepted as history information for an outpatient and office evaluation and management services.
Is this different from policies prior to 2021?
Old guidelines seem to imply that patient providers have to personally ask questions and record answers. New guidelines make it clear that providers can accept the patient's history and use it in the health record. More specifically, 1995 and 1997 documentation guidelines required providers to gather the history into the health record to be scored with a series of grids that tabulate how many history of present illness components were documented, how many reviews of systems were documented, and how many past family social components were documented. These questions, such as duration, how long have you had this problem, and modifying factors, what makes the problem better or worse can easily be answered by a patient. The patient, after all, is the person who is experiencing the medical problem. If the patient is unable to answer questions, perhaps they have a poor vision, then a caregiver, a family friend, or a family member can help ask the standardized questions and record the patient responses. These new policies enhance a 2001 HIPAA privacy rule, which already gave patients the federal right to request to amend their health record.
All right, thank you. Before we address this topic overall, let's discuss the last sentence. The extent of the history and physical examination is not an element in selection of the level of office or other outpatient codes. What does this statement mean?
So this statement makes it clear that documentation of the history and/or examination is no longer a factor in the formula to determine the level of E&M service. The rules have changed dramatically.
What are some of the unintended consequences of this new policy regarding office visit E&M services? In other words, what could go wrong with these new 2021 policies?
Well, the biggest danger is that a patient's needs and concerns may not be addressed and may not be documented into the health record. If documentation of the history is not linked to payment, then there's a lack of incentive to take the time to document the patient's story into the health record. I realize that new rules are designed to reduce provider clerical burden, but there is a possibility that new rules could promote not listening to patients.
Yes, new policies could have unintended consequences of not gathering sufficient patient information, which leaves a patient not heard or understood. How are these new policies in relation to the history somehow better for the patient?
These policies make it clear that patients themselves can author their own history and represent their own narrative in the health record. This reaches back to the work of Dr. Lauren Swede, who promoted the SOAP note for medical charts in the 1960s. S stands for subjective. A patient's history can lose subjectivity if it is written by someone else. When the history is written by the patient, then you really get the person's subjective experience. This new policy is not really new. Medical offices have routinely given patients history questionnaires to complete in a waiting room, or they mailed a form to them in advance of a visit. Those forms from the waiting room did not always make it into the history part of the health record because past policies implied that medical providers had to be the ones to type or write the information into the health record. Many people have experienced going to the doctor and answering the same questions over and over again. These new policies now value what the patients write to the point of accepting the patient's narrative as the history. These new policies allow patients to be heard and understood. They also free medical providers of unnecessary and redundant health record paperwork.
Great, thank you. If a person wanted to complete a prehistory questionnaire and narrate their medical story in the health record at an upcoming medical visit, how could this be done?
As listed in the CPT paragraph, the person should check the patient portal associated with the medical practice's electronic health record or EHR system. If this is functional, then the person can answer all of the history questions and submit it electronically before they attend the medical encounter. Another option may be a questionnaire that can be completed either at home before the visit or in the waiting room. In light of the COVID pandemic, we are not promoting more time in a waiting room. It is a good idea to call your medical facility, such as the medical office, and ask if they provide a history form and how it can be submitted. Another option is to use our research tools, which can be accessed at www.patientadvocacyinitiatives.org. At this nonprofit website, our paper and electronic prehistory forms are available for public use and free of charge. The digital version can be also accessed at www.prehx.com. Both prehistory forms are an exact replica of the history questions as structured and defined by the 1995 and 1997 documentation guidelines. It's basically about 30 questions. Once you complete the paper prehistory, you can turn it into your provider at the medical encounter. Per federal guidelines, as instructed in the CPT paragraph, medical personnel can accept your prehistory and can use it to represent the history in your health record.
Okay, so the message for individuals seeking healthcare is that you are encouraged to represent yourself, Tell your medical story and have it documented as the history in the health record. What if someone does not have the means to complete a prehistory form or something similar to it?
The new paragraphs in the 2021 CPT manual gives a clue when it says, the care team may collect information from the patient or caregiver. A patient may not have internet access or may not have good vision to complete a form. This is where a caregiver, which can be a family member, friend, or professional caregiver, can help the person complete a prehistory. Completing a medical list, which is part of past family social history, for example, can be best done by reading the medication name and instructions directly off of the bottle. Answers to the history of present illness, such as severity, how bad is the problem on a scale of 0 to 10, or modifying factors, what makes a problem better or worse, can be asked and recorded by someone helping the patient.
Is helping a person complete a prehistory difficult to do?
It's not hard to do, but it does take time, especially if you are going for the whole story and want to answer all of the questions. Currently, I am conducting a pilot project with Meals on Wheels to help prepare individuals for a future medical encounter, and am using the prehistory forms on the prehistory website. Most of the time, because the people I visit do not have internet access, we use the paper universal history form to list a chief complaint and prepare for a medical encounter. We also use 2 emergency medical information forms used by the fire departments in Solano County called Vial of Life and Meds. Sometimes we use a digital version if our client has internet access. Either way, it takes more than a couple minutes to complete. Meals on Wheels clients are 65 years and older, and usually there is a direct correlation with their age and the length of their medical history. So it takes a lot longer to complete a medical history on someone who is 95 years old. Asking nearly 30 questions and documenting the answers takes time, certainly more time than is typically allotted for history taking in a medical setting. I am happy to help patients represent themselves in preparation for a future medical encounter or emergency department visit. In case of a medical emergency, such as a fall or stroke, our clients will be able to use their prepared medical history to help advocate for themselves and communicate with the emergency medical service professionals and physicians. Our clients can also better represent themselves at subsequent medical visits by explaining how they feel. For example, after taking a new medication.
Excellent, thank you. Do you think policies in this 2021 paragraph will shift history collection from providers to ancillary staff members and not seek a patient-authored story?
Some might interpret it that way. CMS's Patients Over Paperwork initiative introduced these new policies so providers could pay more attention to patients and less to typing on a keyboard. I think the best practice is to not shuffle the job from the provider to the medical assistant, but rather to empower patients to narrate their own story, which is reflective of their own subjective experience with health and disease. The roles for staff members, such as medical scribes, are changing. As a former medical scribe, I understand the perspective. Roles for scribes and other staff members will shift to be more participative in data collection and documentation. Rather than expect a medical scribe to complete the entire history, which could be done under the new rules, scribes can help collect and represent data that is already assembled by the patient and make sure it is properly displayed in health record documentation. Patients, whenever possible, can author the first draft of the history, which we will call the prehistory. When page 12 in the CPT manual references a patient-authored questionnaire, our prehistory is a good example. Patients can answer these near 30 medical interview questions, which have been defined and standardized by 1995 and 1997 documentation guidelines, and create an insightful narrative of their medical needs and concerns. If patients cannot answer by themselves, then a caregiver, family member, or friend can help patients answer the standardized questions so they are ready for the next medical encounter. Medical scribes can help get prehistory information into the medical record. There is no need to avoid a patient-authored history.
Building upon patients being heard and understood, we have a special guest with us, Lauren DeLuca, who is the president and founder of the Chronic Illness Advocacy and Awareness Group. Lauren, what can you tell us about the need for medical providers to listen to patients and understand their needs and concerns?
I think the most important thing in the doctor-patient relationship is communication. A doctor's responsibility to their patient is to see them more than a textbook case of their disease, but rather a unique person with individual experiences. In the real world, illness manifests differently in every single patient, and every patient is the expert when it comes to battling their own disease. Additionally, encouraging the patient to tell their own narrative helps lead to accurate diagnoses, improved patient care, and ultimately improved quality of life.
What do you think of the new rules that encourage patients to tell their narrative and have it documented in the history portion of the health record?
I don't that the patients are able to narrate and document their medical histories into the electronic health record. I live with symptoms of chronic disease myself, and I need my doctor to understand that I am more than just my disease. My collective life experiences are going to dictate how I respond to treatment that is determined by my physician. I've experienced trauma from providers not listening to my health narrative. I have been injured from not being heard. In our current healthcare system, I've needed to advocate for myself aggressively to get the care that I need. We can resolve these burdens on both the patient and the doctor by going into these visits with our pre-written history, which describes who we are as well as what expectations we have for the care that we're going to receive. From the history we provide, doctors can be proactive in giving us better advice and help us create goals that will improve the healthcare outcomes. Encouraging the patient to be proactive in healthcare serves everybody. One of the best things about the patient being able to document their own histories in the electronic health record is that it ensures accuracy. When a patient describes their health history to a doctor, often there can be a disconnect between what's being said and what's being heard. This creates opportunities for inaccurate documentation. Encouraging the patient to control their narrative allows them to communicate specific details they want their doctor to know and ensures that those details are being documented accurately within their medical histories.
Thank you for that powerful message. I would like to thank all of you for viewing this episode of the Patient Advocacy Show. I hope this episode helped you better understand new health record documentation policies and how they impact medical providers and patients. This community outreach message also includes an IRB-approved survey, which can be found in the description area of this YouTube video. I encourage you to participate in the survey. Our team will track responses and report results back to you in future episodes. Thank you for viewing, and we'll see you at the next Patient Advocacy Show.